ലൈവായിട്ടില്ല. ഇടായിട്ടില്ല.
അത് നോക്കണ്ട.
ഇല്ല, അറിയാം.
20. റെഡി
ആണോ? എനിക്ക് വേണത് നോക്കാം.
ഹെഡ്ഫോൺ ഇടാണ് വോയിസ് കിട്ടുന്നു. വോയിസ് അവിടെ കട്ടാന്ന് അറിയാൻ പറ്റും.
ആ, കിട്ടുന്നുണ്ട്. ഹലോ ഹലോ ഹലോ. We'll just start in a minute. We are going live. Good morning and welcome to AETCM YouTube channel. Today is World Sepsis Day. It's an initiative by the Global Sepsis Alliance which was started in 2012, and this day is basically organized to increase the awareness of sepsis all throughout the world. Today we have a very esteemed panel of doctors to discuss and share their thoughts and clear your queries on this subject. So first I'll have the honor of introducing them to you. I'll start from my right. I have Dr. Deepu TS, who is an associate professor in the Division of Infectious Diseases at Amrita Institute of Medical Sciences. Welcome, Deepu. Dr. Anil Kumar, sir. He is head of the Department of Microbiology. Welcome, sir. And all popular Dr. Girish Kumar, sir, our head of the Department of Emergency Medicine.
Thank you so much.
And Dr. Sri Krishnan, who is my colleague and consultant in the Department of Emergency Medicine. Sepsis is a very, very commonly used and misused and abused term in our day-to-day clinical practice, because every other patient who is dying in the patient, we have the cause of death as sepsis. We have to have some clear distinctions between what is an infection, what is sepsis, and where exactly to use this term. I hope at the end of this session we will have more clarity on the management principles of sepsis and what can be really labeled as sepsis. So let us proceed. I will start the first question with Dr. Sri Krishnan, because as you all know, there has been a lot of changes in even the sepsis definition of late, with the Surviving Sepsis Campaign guidelines and introduction of QSOFA into the diagnosis of sepsis. So, Krishna,
Yes.
What is QSOFA and how is it different from the expanded SOFA score, and is it really useful in the management of sepsis?
Thank you, Shabarish. First of all, as you said, the change in the definition, quickly I just say the change in the new definition. It's basically the dysregulated, due to the dysregulated host response to an infection resulting in an organ dysfunction. That is simply the sepsis now. Previously, there was a lot of definitions for sepsis, and later on by around 2016, the 3.0 sepsis definition came in. And so again, along with that, the QSOFA and the SOFA scoring, how to utilize the new terminology called, they have added just a Q in front of the SOFA score, and they have started using this term. So that is what is QSOFA. Basically, there is a lot of confusion regarding the use of QSOFA scale. It is actually not a very good screening tool. It is not a screening tool, to be correct. It is actually used to predict the mortality, hospital mortality. At the QSOFA score increases from 2, more than 2, there is a 3 to 14 fold rise in the mortality. So that is basically what is QSOFA supposed to be used for. For example, a patient coming to the emergency room basically deals with 3 parameters: respiratory rate, altered mentation, and evidence of hypotension. So these are the 3 parameters that it takes. So if any, each one is given 1 point, and more than 2, we can say that the mortality is going to be high. That is the only thing that we can say by utilizing a QSOFA score. Again, all the patient who we do a QSOFA score, we need to do a SOFA score also. So quick SOFA score may be for an initial purpose, but SOFA score usually contain all the parameters, all the 6 organ parameters that we use, the renal parameters, the lung parameters, the liver parameters, the coagulation profile, all those things will come inside the SOFA score. So when you have a quick SOFA score, we can predict the hospital mortality. And for us as a screening tool, it is not when you just check into somebody is coming with hypoglycemia, they will have altered sensorium. They can have, sometimes they can have respiratory, they can be a little bit tachypnea also. So we cannot just rely upon as a screening tool to find out sepsis. Again, a hyperventilation, very common. We can see hyperventilation, students coming to the emergency room with sudden hyperventilation and sudden panic attack for a situation. That is, again, it's not a sepsis. The best screening tool will be your clinical history taking and your clinical examination of the patient. And the most important thing, you should have a high index of suspicion. The number of patients that is increasing day by day, especially the oncological cases that is coming up, we are not classically seeing the response to like the total elevation in the total count, maybe very low total count also we are not, sometimes we will not be able to see. But always you should have a high index of suspicion in those group of patients where, especially when they are more susceptible for infection, especially for gram-negative sepsis. As you see, the gram-negative sepsis are increasing day by day, and resistance is also going up. The best tool, what I will say, is your clinical suspicion. In a tertiary care center like in our hospital, we need to have like 60 to 70% of the population coming to the emergency room is usually found to have sepsis. So that is how we need to utilize QSOFA and SOFA.
Do you think it can be used as a more of a screening tool than a very high specific kind of a?
See, when we have a good clinical team available, so that you can quickly understand the patient and we can quickly diagnose, okay, possibly the patient falls into the category of sepsis, we can maybe utilize that. But as an maybe for an initial screening tool, where maybe for an EMT who just wanted to take in the patient, he can just do the 3 things and he can say possible sepsis, and then again the clinician can go back and see whether it's a real sepsis by taking a history and a good clinical examination. So that will be my take on it.
I think that sets the ball rolling for the discussion. Next question I will ask Girish sir. Sir, what are the major risk factors for sepsis, or what are the group of patients whom we should be suspecting sepsis really?
So previously we were thinking that only patients who is having low immunity develop sepsis. Okay. Now we know that there are 2 important categories. One, like Sri Krishnan told, it's a dysregulation of your immunity. Other one is deregulation of immunity. So we'll first talk about deregulation. Deregulation means the immunity is not there. Like somebody who is having chronic diabetes, somebody is on steroids, somebody is having HIV infection, malignancy, taking treatment for malignancy, rheumatological diseases, all these things, their immunity is very low. Due to some reason, their immunity is low. That is then they are getting an infection. So that will become a secondary infection in a patient who is having low immunity. So it is deregulated immunity. Immunity is very, very low. But that is an expected thing. When you don't have immunity, you will get all type of infections. On top of that, you are diabetic. A patient who is diabetic, his immunity is very low. When the bacteria come inside, it's a media for growth. The blood sugar is a media for growth. And another scenario is somebody is having malignancy, who is on anti-malignancy drugs. His counts are very low. So whenever there is an immunity, if our counts are good, that will fight against the bacteria or virus, whatever it is. Here nothing is there to fight. So that time the patient's immunity is very, very low and patient develops problem. On the other side, which we are not expecting, somebody is very good, who is immune, who is well built. That fellow is developing a problem, like somebody is having a viral fever. Suddenly patient deteriorates. This is actually dysregulation of immunity. We have good immunity, but due to some reason, it's an exacerbated immune response to that pathogen. That response, even it can kill our own tissues. So that produces more problem than in a patient who is having bad immunity. That is because all doctors expect some problem in a patient who is having bad immunity. Like somebody who is having diabetes, he is having urinary tract infection. We know that any time this patient will go to sepsis, will be more vigilant. But on the other hand, somebody is very stable, who is admitted to the hospital, who suddenly develops a problem because of this infection, something like macrophage activation syndrome. It is not sepsis. But when we are treating a patient like this all come to a single umbrella. whether it is septic shock or macrophage activation syndrome, ultimately for the patient, he is deteriorating.
Okay.
So that we should think, all these things are not there in the guidelines.
Okay.
Like guidelines always say that it's a dysregulation, patient deteriorates because there is no immunity. But here we have a patient who is very good, his immunity is very good. Suddenly due to some simple infection like dengue fever, patient develops something like macrophage activation syndrome. So suddenly patient deteriorates. So that we will not think about that.
Okay.
Suddenly patient deteriorates. But normally what Sabrish told is, what are the risk factors? Risk factors are very, very clear. Somebody is having very low immunity like chronic diabetes, who is on treatment, blood sugars are not getting controlled. That is the commonest problem in our country. Then since we have a big oncology center, we get more of oncological cases, who is having very low counts, who is on anti-malignancy drugs. Then since we have a very good immunology department, we have a lot of immunological problems like rheumatoid arthritis, SLE, all those things. And on top of that, there may be on immunomodulators. Even when we tell immunomodulator, they are also immunodepressants. They reduce the immunity. They also develop all these problems. So in that group of patients, doctor is anticipating some problem. He is ready to treat. But on the other hand, patient is fully stable. Suddenly patient deteriorates. That is the only major difference in this type of patients. Okay.
Right. Thank you, sir. And I again welcome all participants on to the event, and feel free to share your questions in the chat box. We will be taking the questions at the end of the session. So in continuation to that question, so if at all somebody is developing early signs of sepsis, so what are the key things to look for? Like what are the common signs we should be looking for in a patient who is developing sepsis?
So I will not come down from the books. I am going back from the patient to books.
Okay, sir.
So a patient coming to emergency room,
Okay.
you are seeing the patient. You are only seeing the patient. This is the time most of the doctors miss that. Okay, because patient is rapidly breathing. There is one of the most important sign of early sepsis what you can see in a patient who is having acidosis. He breathes very fast. Okay, but most of the time we miss it. We will start taking history. We will not notice why the patient is breathing fast. We may start oxygen. That is not correct. That is one of the earliest sign of any sepsis. Rapid breathing. Second one is like clinical examination. We will be starting examining his pulse, BP and all. Pulse normally when somebody is having normal physiology, will have pulse rate between 60 to 100, something like that. But somebody is having sepsis, he lose large amount of volume from his intravascular compartment. The earliest sign will be always tachycardia. But the only problem in emergency room, many patients are on beta blockers, calcium channel blockers, digoxin, all these things, this response is blunted. So sometimes we will not be able to depend on that problem. Like a patient who is having hepatic encephalopathy, most of the patients are on propranolol or carvedilol. So that pulse response may be blunted. Okay. So pulse rate is very important. Tachycardia, unusual tachycardia indicates sepsis. Next one is BP, hypotension. Persistent hypotension, that is very important. Somebody is having a fever who come with like sepsis. In a patient who is having sepsis, another patient who is not having sepsis. Anyway, fever always reduces the BP. That is because of the vasodilatation. Whereas in sepsis, BP decreases because of intravascular volume loss. Okay. So if you are giving fluids, most of the patients who are not in sepsis or in early sepsis, they may respond to your fluid challenge. But if they are in severe sepsis, they may not respond to your simple fluid challenge. You may have to start inotropes or something like that. So 3 important things you should never forget. Look at the patient, he is breathing fast. Possibly it is acidosis. It can be confirmed with your adjunct like an ABG. Second thing is pulse rate. Pulse rate is very, very important. It's a simple physiological sign. It's very important. But problem is beta blockers, calcium channel blockers, digoxin. Third one is we told about BP. Ideally, all textbooks says you have to ask for a standing BP. And that is not possible in your settings. Like sepsis patient, it is not possible. So we have to depend on simple BP and try to give a fluid challenge. If the patient improves with fluid challenge, he is on the better side. But if the patient does not improve, it's on the bad side. Okay. Again, we can use ultrasound to know what is the IVC diameter whether it is collapsible, non-collapsible, fluid overloaded, fluid depleted. All these things can be detected very easily. Fourth one will be urine output. But most of the time it will be difficult in emergency room, but it is easy to make a chart of urine output in ICU, intake output chart. If your internal organs are perfused well, your kidney also perfused well. So if there is no renal failure, you should have adequate urine output. Okay. So always look for these simple physical signs. Then you can go for invasive investigation, like you connect the patient on arterial BP. You connect this patient for other types of invasive investigation. Then blood investigation. Blood investigations are one of the easiest thing we can be done in emergency department. Dr. Sri Krishna will be telling about point of care blood investigation. I'll be just giving overall idea. We can ask for a complete blood count. If it's a bacterial infection, blood counts can be elevated. Viral infection, it can be low. Then you can ask for platelet count. Platelet count normally in sepsis it is low due to various reasons. I am not explaining why it is reduced. Then another important test will be, again Sri Krishna will be discussing in detail, procalcitonin. That is a very, very important investigation in emergency room. These are simple things you can make from emergency room itself. But there are a lot of multiple tests like echo, very costly investigations like echo, which will tell you the patient whether he is in hypertension due to cardiac failure or due to something else. X-ray should be taken. All these things are investigation. But clinical findings are very, very minimal. But a good clinician can pick up this from early itself, because if you are missing that, you are missing the patient. It's a very, very simple investigation. So sometimes we don't care only. In a busy emergency room, somebody is breathing fast. We normally, if you observe the patient for at least 5-10 minutes, you can understand this patient is in acidosis. He is in danger. Okay.
I think that very much clarifies the importance of assessing the patient physically and picking up the early signs by seeing the patient itself. But so as from the science, yes, already mentioned about the investigation part also. Now we have the best person to answer and give us more details about that specific topic. So the question to you is, what are the biomarkers available for sepsis management? And there has been a lot of interest regarding procalcitonin. So if you can just help us understand when and how to use procalcitonin judiciously.
Thank you, Sabrish. That's a difficult question because biomarkers have not come that way as other diagnostic procedures have come in sepsis. So we have very limited number of biomarkers available. The historical ones is CRP. CRP has been used, but we all know it is non-specific, so it cannot correctly predict sepsis. ER you get trauma, burns, everything will have elevated CRP. Having said that, the next best marker would have been procalcitonin, and procalcitonin is widely being used, as sir has already told, and people depend a lot, bank on procalcitonin a lot. But still, having said that, procalcitonin is also non-specific in the sense that trauma, burns, accidents, cardiac surgery, viral infections, malaria, fungal infections, you have cardiac arrest. People come with cardiac arrest and insult in the heart. So these people will have an elevated CRP. And having said these things, we are a tertiary care, quaternary care hospital. We see patients with CRRT, renal failure. All these people have got an elevated procalcitonin. But the procalcitonin level would be slightly higher. The cutoff that we use for normal patients would be 0.5. And if you say about a CRRT patient or renal failure patient, the cutoff would be slightly higher. We should have keep that in mind when interpreting procalcitonin. The procalcitonin is a very, very good marker in the sense that it has got a very good product, 80% of sensitivity and specificity. That's a good value when you think about diagnosing sepsis in an ER with a single marker. So that's a very good thing. And the beauty of procalcitonin is it has got a very short half-life, 24 hours. And if it's non-specifically elevated, it will go down. 24 hours, it will go down. So 24 hours is the time you have. You repeat it again and see if it go down, then he's having some other insult that is leading into the rise in procalcitonin. Sepsis, it will continuously increase as long as the septic cause etiology is still there. So procalcitonin of more than 0.5, think about sepsis. 0.5 to 2, you can think the patient may go into sepsis. 0.5 to 2 may also indicate a localized infection, a pneumonia, an abscess, something, a urinary tract infection also. But anything above 2 is considered to be sepsis. More than 10 is septic shock. Don't think about it. And studies have said that you can see the value and also gauge which infection it is. So if you have a low procalcitonin 2 to 10 or 2 to 5, you may think it's a gram positive sepsis. But you have something say, more than 8 and more than 10, think about a gram negative. So you can have stewardship also implication. Dr. Deepu would be speaking on it. So you can broadly classify them gram negative, gram positive sepsis. Most often we have gram negative sepsis. So most often our patients would have a highest procalcitonin level. So we have to rule out the first, as I started, you have to look at the symptoms, signs, clinical signs. Then order a procalcitonin. Don't order a procalcitonin in a renal failure patient, it will be increased. Unless and until, as sir had told, you see a respiratory rate, pulse, BP, everything. So, renal failure patient, procalcitonin doesn't signify anything. An unknown person would say, it is high, we start an antibiotic therapy. So that's not logical. You should be judiciously using in people who you think are likely to go into sepsis or having sepsis. Then you take a decision to order a procalcitonin. Presepsin is another marker that has been there since 2005, but it's not very commonly used. And recent studies, some anecdotal studies have been done, and they say that more than 110 can discriminate between septic shock and sepsis. But beyond that, presepsis has not been widely used, so we don't have much of detail or knowledge about how to go about using presepsis or whether it's superior to procalcitonin. As of now, procalcitonin is a very good marker. You can use it judicially and think about the cutoffs when you use it. Think about the patient and then use the cutoff.
Okay. I think that makes it very, very clear. So, one more question to you, sir. Moving on to organism specific diagnoses and things, what is the role of a gram smear? Then definitely culture remains the gold standard, and there is a lot of interest from the West regarding MALDI-TOF. So if you can just help us understand what is the real role of these things.
So we have to classify sepsis as primary and secondary. Primary, secondary bacteremia, that's what they say. So most often you may have a secondary bacteremia patient with having a UTI which is going into sepsis, an abscess which is going to sepsis, a pneumonia that is leading into a sepsis. So there a gram stain becomes very important. A gram stain from a respiratory specimen, a pus specimen, a urine specimen, or any CSF specimen, anything that is causing the infection and you think the patient is in sepsis. But some people order gram stain of blood. We have seen very rarely people do it, but you should realize gram stain of blood cannot be done. It is not routinely done, doesn't give any idea whether the organism is there or not. So don't order a gram stain of blood, but you can order a gram stain of pleural fluid, CSF, synovial fluid, anything that is causing a secondary bacteremia, you can do it. Blood should always be cultured. And you have to interpret with the normal flora. You send a respiratory specimen, you will say the gram positive cocci is plenty, gram negative bacilli may be seen, or gram negative cocci, it could be Haemophilus, it could be Streptococcus. So you should understand that this doesn't signify it is an infection. Think about the patient. If he is having pneumonia, then you think of doing it, otherwise it doesn't. And you have to see the amount of pus cells. If you see plenty of epithelial cells being reported, it's a salivary contamination and you won't get a good report from there. But sterile body fluids, if you see even one bacteria, it is significant, but rarely we do, because bacterial load is not very high in CSF, synovial fluid or pleural fluid. But if you see a bacteria in the sterile body fluid, go ahead and treat it. You get a good opinion about what antibiotics to be used using a gram stain. A gram stain can guide it. Then coming to MALDI-TOF, MALDI-TOF is something that can be used only on culture isolates, not on direct samples. So we don't have the time advantage. And the instrument, the amount of investment you have to put is huge. And it is not relevant in our setups where we have to wait for the cultures to grow. Culture yield is not that great. So only if the culture yield is very great, you can use a MALDI-TOF to get an identification on the second day after the bacteria grows. But having said that also, most of our bacteria is E. coli and Klebsiella. Even my lab technician can look at it and tell you that it is E. coli and Klebsiella. You don't need a 1 crore equipment to tell it that it is E. coli or Klebsiella. Anyway, you have to do a sensitivity to next day to give it a susceptibility report. The MALDI-TOF doesn't give you a susceptibility report. It has an advantage when you are identifying non-tuberculous mycobacteria, Candida speciation can be done rapidly, or unusual mycobacteria like Burkholderia, Cepacia, Pseudomallei. Otherwise, it doesn't have much of a use in a clinical microbiology setup as of now. But as the days go by, we advance and our yield increases, MALDI-TOF will have a very good use, because they say that they can use it directly in blood culture positive specimens, blood culture positive broth, to know whether the organism is a carbapenemase producer or not. So that gives you an idea whether you have to go hike up to Septazidimabactam or a colistin. But it's still in the process, but it's not yet come. So when you are able to use MALDI-TOF directly on sample, it makes a difference, but not on culture.
Perfect. Yes, sir. Thank you, sir. Next question to Krishna. Krishna, the new sepsis guidelines has been emphasizing a lot on care bundles. So we have been having our 3-hour bundles, then the 6-hour bundles. Now we have the 1-hour bundle. So if you can give us some clarity regarding what are bundles and what is the real relevance of it in management.
See, when we were studying way back in 2008, we had the 3-hour bundle, 6-hour bundle, and to go with the EGDT, early goal directed therapy. So that was the thing that was happening long back. But recently, the surveying sepsis campaign guidelines with the Q SOFA updates, they have come with something called as a 1-hour bundle. With there is lot of debate, but there are certain very relevant points that needed to be done. If it is within 1 hour or 2 hour or 3 hours, we need to do it as early as possible. You can name it whatever it, but these are the mandatory things that you need to do for a patient who is coming with sepsis. The first thing that will be measuring the serum lactate. So as early as possible, you measure the serum lactate. So we have a point of care blood gas analysis machine. So we can get along with the blood gas analysis, we can have the measure the lactate. So not only first measurement, you need to have a measurement later also after your treatment with your fluids or antibiotics, whatever be that. After 2 hours, it is also ideal to see what is the lactate level and whether there is any clearance of lactate is there or not. So that will be the first thing. Then drawing for blood cultures. So again, one thing that is very, very important when you have a sepsis patient, but in a busy emergency room that we get a lot of calls from Anil sir regarding contamination, that can happen. But drawing a blood culture is one of the important things that mandates prior to administering the antibiotics. Drawing a blood culture is one important thing. Maybe sir will agree to that. Maybe anaerobic we don't need. Maybe an aerobic panel is more than enough. At least so that the contamination can be prevented from an BCER. So one again with the PP kit on, so we are seeing a lot of contamination that is also happening. But guidelines suggest to take a blood culture, but it's also appropriate that after maybe 3-4 days we don't get an answer because we already started antibiotics. So always make a priority to send a blood culture before starting your antibiotics. Then administering a broad spectrum antibiotics as early as within 1 hour. That again we had our good experience with our limited available data also, that it will definitely increase decrease the hospital stay and patient mortality. There was a significant reduction when the antibiotics are administered as early as within 1 hour. Maybe there is some problem, but as early as possible, maybe at least within 3 hours. That's what I will suggest. Definitely possible within 1 hour, that is ideal, but don't delay the broad spectrum antibiotic administration. Then fluid resuscitation need to be initiated. That again, there is a huge controversy regarding the fluid resuscitation. To start with, there is no confusion, 30 ml per kg of crystalloids. That is a fluid that you can start with. Then how fast is the next question. So how fast? Within 1 hour, within 3 hours, maybe you start initially within 1 hour, you need to start the resuscitation and you complete the fluid management within the next 3 hours. So at least that clarity should be there. There are a lot of debate ongoing in this regard. Many say that you need to give as early as possible as a bolus fluid. Many say that you can extend it over maybe 3 hours. But to me, what I will suggest is that depending upon the patient's response, what is the fluid response of the patient? What is the fluid status of the patient? You assess using your ultrasound. You see the IVC collapsibility. If already the IVC is already full, there is an associated septic shock along with an cardiogenic shock also. We should be judicious in using the fluid at that time. So these are all guidelines that to guide us. But patient to patient, it will vary. So you start with 30 ml per kg. If the IVC is collapsing, you can have other parameters also like passive leg rising test and all those things. So depending upon the clinical status, you start the patient on an IV fluid and start resuscitation for your hypotension. And the next thing will be to start on an inotropic or a vasopressor agent if MAP is less than 65 and remeasuring the lactate. So again, the agent of choice will be the noradrenaline to start with. So these are the sepsis bundle assets within 1 hour bundle, the so-called 1 hour bundle. So there are it has been replaced all other bundles as if now, because this bundle theory has been updated by the surviving sepsis campaign guidelines team, and this is the recent bundles that we need to follow. The most important thing is that measure the lactate after 2 hours and see the lactate clearance, and administer a broad spectrum antibiotic, draw a blood culture prior to administration of your antibiotic, and fluid therapy of choice is again crystalloids. Is the fluid of 30 ml per kg is the fluid bolus, but depends upon the patient fluid status you decide, and also the cardiac status, because a lot of patient what we are getting is a combination of sepsis with a cardiogenic shock. It can be an already existing cardiac failure that has worsened, or maybe due to sepsis itself there can be an underlying myocarditis, it can be worsening. So you have to be use fluids judiciously, but there is no doubt that you need to start the patient on fluid and measure the lactate, and if it is more than 4, definitely there is hyperlactemia. More than 2 itself hyperlactemia, more than 4 with acidosis there is lactic acidosis, there is no doubt, and you need to start them on fluid and inotropic resuscitation depending upon that. Okay.
You mentioned about the role of early antibiotics. I think that's one of the most key thing in the management of sepsis. So we need to have a little more clarity on this role of antibiotics. I'll come to Deepu. Deepu, how to choose the empirical antibiotic? If you can give us some idea about what to choose when.
Thank you, Dr. Shabrish. So, Girish sir already told us when to suspect a sepsis, and Anil sir has told us, how the gram stain can help in identifying the organism and trying to figure out what empiric antibiotic to be given. But that being said, I will stick on to the topic, that is the empirical antibiotic. You are suspecting a sepsis and now you have to start with empirical antibiotic. So I would suggest a simple approach. Consider 3 factors. One is the environmental factor, second is the host factor, and third is the pathogen related factor. So, like for all the patients, before starting the antibiotic, you can go through these 3 things. So first, coming to the environmental factor. So you can see whether the patient is coming from the patient has presented to you with sepsis, with features of sepsis. Now you can ask the question whether there was any recent hospitalization. The patient is coming from another hospital, or the patient is coming from the community. So if the patient is coming from the community, then it is a community acquired infection. If the patient is referred from another hospital, then it is likely to be a hospital acquired infection. So whether it is a hospital acquired infection or community acquired infection, that can help you to narrow down your antibiotic of choice to a higher end antibiotic or to a lower end antibiotic. Which antibiotic we can, I will tell towards the end of the discussion. So this is one thing you can always ask, whether it is a community acquired or hospital acquired infection. Second thing is the host factor. Host factor, we already discussed few of the host factors, like if the patient is a chronic diabetes, or if the patient is having immunocompromised situations, post-transplant, neutropenic, post-chemotherapy, malignancy. So these are the group of patients who already have a very weak immune system. So in this group of patients, the problem is that for a patient who is neutropenic, you are not going to get a lot of window of opportunity to experiment with the antibiotics. So if the host is very much immunocompromised, if the host is very much morbid, then you might have to go for a higher end spectrum, because the window of opportunity to treat the sepsis is kind of narrow in comparison to a healthy immunocompetent individual. So this is the second point we need to remember. And third is the pathogen related factor. Of course, the pathogen related factor is again will cross over with the environmental factors, that where the pathogen entered your body, whether it is in the hospital setting, whether it is in the ICU setting where you have a lot of tubings and central lines and catheters. So if that is the setting in which an organism entered your body, then again that can be a multi-drug resistant kind of organisms. Okay. So if you are suspecting, if from the history, if you are seeing a immunocompromised host, hospital acquired infection with a possibility of MDR organism, go for a higher end antibiotic like BLBLI. Piperacillin, Tazobactam, Magnex, Cefoperazone, Sulbactam, or higher up 4th generation, or even Carbapenem. But if you are having a community acquired infection, and maybe, of course, you can look for the focus of the infection, the criticality of the infection. All those things has to be taken care of. So it is never a single answer, but it is a composite endpoint of your analysis. And once you have that analysis, and if it is a community infection, pneumonia, then you know that it could be a simple organisms like Streptococcus. So ceftriaxone plus azithromycin should be good enough. So I think that view we all should have.
Okay, I think that makes it very, very clear. I think it's impossible for us to suggest one antibiotic as an empirical antibiotic, but the principles Dr. Deepu had very, very clearly told us. So a lot of things will depend upon the factors, 3 factors he has told, and then to choose based upon that. Just expanding on this line of topic itself, sir, if you can, the most common kind of sepsis which we are seeing here is bacterial sepsis, and Deepu also told regarding the gram positive and gram negative. So if you can just little more elaborate on that topic, what are the common gram positive, gram negative infections, and what are the sites which we see commonly?
So when we talk about bacteria, Dr. Anil will be a better person to talk about bacteria. I can only tell where all you get common infection. Like one of the commonest problem in emergency room will be urinary tract infection with sepsis. You take the urinary tract. Somebody getting community infection like Debu told, sometimes it will be gram positive, sometimes it will be gram negative, but they never go to sepsis. But a patient who is sick, like who is having some comorbidities, he can go to sepsis because of urinary tract infection. And that most common thing is always gram negative infection. It can be E. coli, it can be Klebsiella. So many other gram negative bacteria can produce infections there. But again, when you are treating a urinary tract infection, always try to get previous reports, like its previous culture reports. Some patients you can see the same type of bacteria seen in all cultures. Another type of patients, every time you are getting a different type of bacteria. In that, you will get an idea that this bacteria is harboring inside the urinary tract somewhere. If the same type of culture is coming every time, every 3 months he is getting an infection, every time culture is showing same bacteria, then you are not eradicating that bacteria completely. So you can easily treat that bacteria with previous reports. Whereas another patient who is having repeated culture reports, that means he is getting an infection from outside, even from his partner also you can get infection. So in that case, you have to be very careful. But since the most of the things are gram negative infection, you have to cover for gram negative. Okay. Again, Sir has already told about ESBL and all. He'll be discussing about ESBL. That report, you should be very careful. You should read that report, and according to that, you may adjust the antibiotic like Debu told. Then second common infection what we are seeing is abdominal infection, whether it is peritonitis, GI infection secondary to liver disease, all these things, again it is gram negative infection. So again, E. coli is one of the commonest thing. The Klebsiella can be there. So many other gram negative bacteria can be there. Again, the antibiotic of choice will be same. But you have to always look for the ESBL and all these things in previous culture reports if it is available. Otherwise, empirical antibiotic like Debu told, we can start. That is gram negative infection. Okay. Go above, we have lungs. Normal person coming with a lung infection, it has to be gram positive cocci. But most of the time what we are seeing, they never go to sepsis. Very rarely gram positive infection with like community acquired pneumonia, they go to sepsis. Whereas a patient who is having diabetes, who admitted to another hospital, from there he is getting referred, or the patient is on ventilator, then we are getting, most of the time these bacteria are gram negative organism, like Pseudomonas or something. MRSA can be there. That depends on chest X-ray and all. We can tell. Sometimes you can get cavities in the chest X-ray. You can think about MRSA. Okay. Otherwise, most of the time, these bacteria is also gram negative infection. But sometimes we can track that patient. You can see from which hospital this patient is coming. Okay. What type of infection was there in these type of patients when we get refer from that. Because these all things are possible only in tertiary care center. Okay. Otherwise, it will be difficult. But what I told is, a patient who is having normal lung will have a gram positive infection. A patient who is having a damaged lung will be mostly gram negative infection. So 3 areas, important areas we covered. One is urinary tract, including pyelonephritis, abdominal infection, lung infection. Predominantly it is gram negative. Meningitis and all, very rarely it produces sepsis. We don't get anything like that. But another important reason for sepsis is gram positive infection. Books have mentioned that it has become equally important like gram negative. Okay. But we are not seeing it properly. That is because we start antibiotic for every sepsis. Okay. A patient who is having skin infection, like who is having cellulitis, lower limb cellulitis, a patient who is having ascites, pedal edema, they suddenly develop cellulitis in the lower limb. Or elephantiasis, they develop cellulitis, repeated cellulitis. Most of the time, this is gram positive cocci, streptococci or staphylococci. Sometimes they respond to your antibiotic. Sometimes this will be resistant to your routine antibiotic like amoxicillin or something like that. So we call it as MRSA or something like that. Resistant to the routine penicillin. Okay. In that case, this is predominantly gram positive cocci. Okay. So whatever we are seeing in our country, in India, predominant infections are gram negative infection, wherever it is. Okay. But skin infections are very common in conditions like chronic diabetes, who is having pedal edema, patient who is having liver disease, who is having pedal edema, patient is having elephantiasis. All these conditions, gram positive cocci infections are very, very common. But what happens is, if the patient is not getting adequate treatment, slowly gram-negative bacteria grows there. So then it will become a gram-positive with gram-negative infection.
Okay.
So if you know from where the focus is coming, and if you get the previous culture reports, you can possibly tell this may be gram-positive or gram-negative infection. You can start an empirical antibiotic, like Dibu told. We have to always look for the patient and see where is the infection. Like Sir told, procalcitonin will tell you if it is less than 10 it is possibly gram-positive. More than 10 it will be gram-negative. So all this clinical correlation you have to treat the patient. But as an emergency doctor, we always try to start broad spectrum antibiotic. As a infectious disease person, Deebu also agree. They try to narrow down the spectrum and they try to start exactly what antibiotic is required. That de-escalation has to be done from their side. Okay.
Clear. I think that again clears that problem. And one thing is, we are, as Sir and Dibu has told, most of the infections we hear are bacterial, and among them gram-negative definitely has a higher predominance in India. But at the same time, we cannot, Dibu will agree that we are seeing a lot of fungal infections also nowadays, and that's definitely on the rise. So if Dr. Dibu can just put some insights into fungal sepsis and how different is the management of fungal sepsis from bacterial sepsis.
So basically the fungal sepsis also has to go through the same principles of bacterial sepsis regarding the fluid resuscitation, regarding the clinical signs. So as far as the management goes, other than the antibiotic or antifungal part, rest of the things remain. And now the thing is that when will you suspect a fungal sepsis? That is completely different. You will never suspect a fungal sepsis when a patient coming to the casualty if there is no proper setting. The setting for suspecting a fungal infection has to be there. So, there are a lot of scores, including Candida score, where you will look for certain points or certain risk factors which could prepone a person to develop a fungal infection, which include, of course, hospitalization, especially prolonged hospitalization. Prolonged hospitalization, treatment with broad spectrum antibiotics. And if the patient, especially in ICU, then the chance of him getting fungal infection is high, especially with devices like central lines and other catheters. So central line associated fungal infections. Then, recurrent history of hospitalization. That itself is a risk factor. Of course, immunocompromised host, including neutropenic patients, ours being a tertiary care center, we tend to see a lot of patients who have that kind of poor immunity, whether it be post-transplant, whether it is post-chemotherapy. So those group of patients are by default have a high preponderance for developing fungal infection. So these are the setting in which we start suspecting fungal infection. And when there is a fungemia, always if there are some devices or some focus of infection which can be removed, always we should try and remove that focus. Then only the fungemia is going to clear. Otherwise, even if you are giving your best antifungal, the patient is not going to respond. So trying to remove the focus is very important as far as fungemia is concerned. Then the thing is that if there is no focus and if the fungemia is persisting, then definitely think of endocarditis. Candida endocarditis is very much important.
Yes.
And it could lead on to seeding also. So that is another thing we usually not tend to think, but we have to think. So, and apart from bacterial sepsis, this fungal sepsis tend to be more of like a resistant type. Hence, at the end, we have to serially repeat the Candida blood cultures, ideally every 24 hours, but for practically every 48 hours is okay. And once we have to ensure that the last culture is negative. From the day of last negative culture, again, ideally we have to treat for 14 days to prevent recurrent fungal infection. So these are the major points which we need to think. And one more thing I want to add is that, because right now, previously we used to get lot of Candida tropicalis and other sensitive fungus, but now we are seeing more of resistant fungus, including Candida auris. So thing is that we need to keep that in mind. So with all these resistant infections, when you see a candidemia and if the patient is having some kind of severe form of sepsis, always tend to start with an echinocandid. I know it is very costly, it can cost up to 10,000 per day, but still if the patient is affordable, if in the hospital setting, if you are getting a candidemia, you have to start with an echinocandid, and once the culture and sensitivity report is available, it is better to de-escalate.
Okay. That very much clarifies the point. But to know whether we are having a bacteria or a fungus, we have to rely upon the culture. And the culture, as Krishna told, there can be multiple problems with contamination, etc. So, and sir, if you can give us some real clarity on how to collect and how to send a blood culture, or for that matter, any culture.
As Sri Krishna has accepted, contamination rates are high in ER due to plausible reasons which we are very much aware of it. You work in a area where you are doing everything, multiple things at a time, and the patient may have seizures, many other things. We are not able to prepare the site properly. So contamination is historically high in samples coming from ER. So that defeats the purpose of blood culture. So, but they have limitations in the setup. But as soon as possible, you try to collect a blood culture. Now, giving an antibiotic is not a contraindication for blood culture. Don't think that you have already given an antibiotic, you can send. You always send a blood culture, ideally before giving an antibiotic. Even if it's antibiotic given, you would send a blood culture. It will, if it grows something, you are a definitive diagnosis of blood culture. Sepsis, it's a gold standard. So blood culture should always be done. Ideally, 3 sets of blood culture is needed by European standards or Western standard. But 3 sets means 6 bottles, and each set contains 2 bottles. Ideally, they say recommendation is aerobic and anaerobic bottle. But there are 2 schools of thoughts. One says that aerobic anaerobic is required, and I am in the other school of thought which believes that the 2 aerobic is far better when compared to aerobic and anaerobic. I'll give you the reasons. The reasons being that you send an aerobic and anaerobic bottle in community patients who are suspected of infective endocarditis or PUO, you said it, because anaerobic bottles have got good yield in case of streptococcus that may cause an endocarditis, alpha-lytic streptococcus that may cause an endocarditis. Otherwise, if you are seeing, most of our patients are healthcare associated patients. They are in and out of hospitals. They come here because they have not got a proper treatment or were not being treated properly somewhere else, and they are complicated, severe. So these patients ideally go for aerobic blood cultures. The reason I am saying that, as environmental factors, Dr. Deepu has said that the patient may come from a hospital, he has got risk factors for hospital-acquired infections. And what causes hospital-acquired infections are Pseudomonas, Acinetobacter, Burkholderia cepacia, and Candida. Okay. So candidemia you cannot suspect by seeing a patient, as Dr. Deepu has already told you. The only way to prove candidemia is blood culture. So send an aerobic blood culture, pair of aerobic blood culture bottles, 2 sets of blood culture bottles because we have cost constraints. So if you are sending only 2 bottles, send one from a peripheral site, one from 2 different sites. If you think a central line associated infection is the reason, you send 1 bottle from a central line and 1 from the peripheral site. So I would recommend ideally 4 bottles, that is 2 sets of blood cultures from 2 different sites. 2 different sites is very important. You just don't fill the 4 bottles from a same central line and give it. It doesn't make any sense. If one is contaminated, everything is contaminated. The reason for sending more than 1 bottle is that if one grows coagulase negative staph or a dipteroides or a bacillus, you know it is contaminant. You don't need to treat it. Because what Dr. Sri Krishna, Dr. Girish, or Shabrish or Deepu gets a call from a lab, the moment blood culture comes positive, is a gram-positive cocci growing. And the immediate knee-jerk reaction is start vancomycin. So that gram-positive cocci is most likely to end up as a coagulase negative staph. You don't need a vancomycin at all. So if you send a 2 blood culture bottle, only 1 blood culture bottle is positive. We can wait if the patient is stable. You don't need to start vancomycin immediately. If the second blood culture drawn from a different site also grows a coagulase negative staph, then it is significant. Go ahead and treat it. More likely to be significant. But if you still have some doubt in your mind, there are studies who have said that you can do a procal. If you grow a gram-positive cocci in blood, you are thinking it could be a contaminant or a pathogen. You do a procal of more than 0.5 in a patient growing gram-positive cocci in blood, could be significant, could be sepsis, go ahead and treat it. So procal comes to help you in these situations where you are not able to decide whether it's a contaminant or a pathogen. So always send at least 2 sets of blood culture, that is 4 bottles. Always send aerobic bottles when the environmental factors are hospital-acquired infection, because aerobic blood cultures will only grow Candida, anaerobic bottles will not grow Candida. So if you send 1 aerobic and 1 anaerobic bottle, you lose 50% chance of picking up a Pseudomonas, Acinetobacter, and a Candida or a Burkholderia that is commonly seen in hospital-acquired infections. Okay. So always it's better to pick up these rather than picking a Streptococcus or Staphylococcus using an anaerobic bottle. Yeah. So go ahead with 2 aerobic blood culture bottles for each set.
Okay. Thank you, sir. Krishna, I think the two major components of the sepsis bundle we discussed regarding the blood culture and antibiotics. The next thing will come to the management of shock. So, if you can throw some light regarding the fluid management, is there any role for albumin, and also what inotrop to choose in management of septic shock?
Again, there has been a lot of debates and study regarding crystalloid versus colloid, and there's been debate that is going for a long time. But one thing that is very clear, we need crystalloids for fluid resuscitation. That is very pretty clear and straightforward. 30 ml per kg you can start with if there is any evidence of hypotension or the lactate is more than 4 millimoles per liter. So that is pretty clear and straightforward. And there are situations where albumin has been tried. The classical SAFE study where they have seen used crystalloids versus albumin, and they have found out that no major benefit over over albumin over crystalloid. There was no major mortality benefit. So only in one circumstance where definitely an albumin will be of a choice will be a patient with a chronic liver disease who has hypoalbuminemia, maybe with hypotension. And again, a cost factor is a huge thing to give albumin. That is only one place where we can suggest maybe albumin as a first initial fluid of choice, depending upon the availability and the cost factor. So that is one thing where albumin has got a little bit edge. And the rest, when you see for the hydroxy, they'll start pendastars, there are no indication at all to start in the ED. You can definitely go with the crystalloids. So there has been no benefit for other crystalloids, only benefit no benefit for other colloids. The only benefit that has been found with the albumin in case of an hypoalbuminemia associated a liver failure. That is the only one area where we can try albumin as a fluid resuscitation. Again, a percentage is a little bit different, not the routine percentage what we get as 20%. We have to dilute it further, or again the availability is a big question. So that is regarding your albumin, the fluid of choice. Then coming to the vasopressor therapy, to be very precise, because inotrop, the classically it has to increase the heart rate, and to be in a septic shock situation we have to dealt as the peripheral vasodilation as the major issue. So it will be a vasopressor agent that we need to start, and the vasopressor of choice without any doubt is noradrenaline. So noradrenaline is the agent of choice for septic shock. When you see management of shock, majority of the area, it is the drug of choice is now is noradrenaline. So again, the question arises is that whether you need a peripheral line, central line, where how to start noradrenaline. Maybe initially you start with a peripheral line, later on convert it to a central line. Whenever you have a technique available, you have a technician who can handle a central line, or whether the doctor is trained himself to put a central line, you can change over to a central line. Till that time, it is safe to start with a peripheral line, but maybe within the next 4 to 6 hours, think of converting into a central line and starting via central line. So that will be an ideal to start with, will be the noradrenaline. Then the question arises is when we should think of starting a next inotrop. So always there has been a practice to use the maximum dose of the first agent, that is use the maximum age of noradrenaline, but it is always preferable if it is more than 50% of the recommended dose, go for the next inotrop, next vasopressor agent, that is the second line agent is the vasopressin. It is the drug of choice. Again, there can be a question, why not dopamine? So dopamine, again, you classically know it increases the heart rate. So again, in sepsis there is a tachycardia, a lot of tachycardia. It has got alpha effect as well as the beta effect, but the problem with dopamine is with the tachycardia. So where you can use dopamine, maybe a patient with bradycardia and you have a sepsis and you need to start on a vasopressor agent, maybe dopamine will be an agent of choice. That is only one area where you can think of starting dopamine as an agent of choice. So you have started noradrenaline, you have moved on to the other agent if required, and again the role of refractory septic shock, where we think of a smaller dose of steroids. The drug of choice again it is hydrocortisone, 50 mg q6 hourly, or fludrocortisone. That you can stop it after 5 to 7 days of your once the hypotension settles, you can stop the hydrocortisone injection. So that is the next agent of choice. Then always consider that, as I told before, there can be a possibility of associated cardiogenic shock also. So the classically, when you see a patient with shock into the emergency room, you are getting a BP of 70 by over 40 and you have a warm periphery. You are able to feel your dorsalis pedis even with a 70 by 40. You are classically dealing with a septic shock alone or a distributive shock alone. So maybe noradrenaline fluid resuscitation with a noradrenaline will be sufficient enough. So the same group of patient along with septic shock, he can have an associated cardiogenic shock where he can have a cold periphery. So it can be a combination of both septic and cardiogenic. One will be superriding the other. So again, you have to assess the LV status, and you need to decide to start the patient on an inotropic agent once the systolic BP is above 90/60. So you first initially build up your systolic blood pressure over 90/60 or 90 above the systolic blood pressure, then add an inotropic agent like dobutamine. So that will be the usage of vasopressors and inotrope. In a brief, in an emergency room setting, we can start in a peripheral line, move on to a central line maybe within the next 4 to 6 hours. Okay, sir.
So just extending that management of shock to Deepu. Deepu, I think there has been a lot of interest regarding the metabolic cocktail and vitamin C. We have our own paper published. So if you can just briefly say where we stand now on vitamin C and the metabolic resuscitation part.
So in our paper, that is the Victor trial, what we have done is we gave vitamin C, thiamine and hydrocortisone, and it was a randomized control trial with standard of therapy. Definitely we could not prove a mortality benefit, and as far as I know, like no other trials could prove a mortality benefit. But one thing many trials, including our trial, were able to prove is that there was an early weaning off from the inotrope. So definitely it has that ability to, that vasoplegic, anti-vasoplegic effect of vitamin C is definitely kicking in. So if the patient is on multiple inotropes, and if there is a requirement to taper off the inotrope at a faster rate, this can be still tried.
Okay.
But mortality benefit as of today has not yet proven. So we cannot recommend for that particular purpose.
True. Okay. Krishnan, there has been again another major thing which has generated a lot of interest is use of point of care ultrasound in both in as hinted regarding the IVC assessment, and also for probably some early diagnostic tool also. So if you can just throw some light on that.
Again, POCUS, wherever you're able to put your ultrasound probe, put the ultrasound probe and use it in the emergency department. So whichever area you can put an ultrasound probe, you can use that. So especially in sepsis, that got definitely a huge role. As I said before, IVC. So in visual vena cava, respiratory variation or even compressibility, or what is the diameter of IVC. So definitely it has got a role. So that will be the early use for your hemodynamics, to understand the hemodynamics of the patient. And the next will be the next important thing, maybe to look after your echo. What is the ejection fraction? How good is the ejection fraction? Whether there is any associated minimal tamponade effusion, whether there is an associated obstructive shock. So all those things, again, your point of care ultrasound is going to help. And if the patient is breathless, if there is an early ARDS, you have got a B lines. Again, you can put over your chest and you can understand what is happening into the lung. Evidence of pleural effusion. Everything you can easily do a bedside diagnosis with the help of your ultrasound. The most important tool, the next thing it will be to put a center line. It has to be guided with the help of your ultrasound. That is a recommendation, standard of care. Even if you're not able to get a good peripheral line, because initially you need fluid of choice, that crystalloid need to be given via peripheral line. You need a peripheral, large bore IV access in the peripheral line. So again, ultrasound usage in the peripheral, to put a peripheral line is also very hugely important. You can place it over your cubital fossa, and you can look for your veins, and maybe a large 18 or 16 gauge cannula can be put. So again, ultrasound, definitely it has got a role. But if you don't have an ultrasound, that is the next question, because it is mandatory to have an ultrasound machine in an ED now. But if you don't have an ultrasound, you can go for other resources like the classical capillary refilling tank. But again, in sepsis, the problem is that it is a vasodilatory shock. So capillary refilling time will not help you much. So one thing what you can do for assessing the fluid status will be your passive leg raising test, which is a simple maneuver where the patient can be kept initially in a semi-recumbent position rather than the classical supine position recommendation. You can keep the patient on a semi-recumbent position, measure the blood pressure at that position, and ideally don't touch the patient and hold your hands and move the upper limb, rather than you try to move the bed. That is a recommendation now. You can just try to move the bed. So you should have an automated bed like that. You try to move the bed and passively raise the leg and see what is happening to the blood pressure. So once you do that, if there is hypotension, around approximately, what the evidences is show that approximately it will show that around 300 ml of fluid deficit. So when you are raising the leg, 300 ml of fluid is going to come inside, and so that the hypotension will decrease. So if you're able to see that changes, and you can definitely go for a fluid therapy for that patient. And again, urine output is again a very good marker. So point of care ultrasound, definitely yes, whichever lines, whichever tubes you wanted to place, you need as ultrasound. You need to look for the variation, you need to look for the ejection fraction, tamponade, B lines, all those things your ultrasound is going to help. So that will be the role of ultrasound.
Fine. Coming to Girish sir. So one key concept in management of sepsis is the source control, but often at times people forget about this concept of source control. So if you can just tell us the importance of this in management.
So one important thing what we learn in our MBBS days is wherever there is pus, remove it, because pus is a continuous source of infection. It is from there it is continuously spreading this bacteria, virus, whatever it is to our bloodstream. So wherever pus is there, how much ever small it is, remove it. Okay. Most of the time we have a hesitancy to remove it because patient come to emergency room, he'll be in hypotension. We are seeing a focus of infection, but we always try to correct the problem in this patient, acute problem, like we try to manage the hypotension, all these things. Simultaneously, if we can remove that source, then it will be very good. Otherwise, unnecessarily, we will be giving antibiotic. One of the problem of antibiotic in this type of pus collection, whatever antibiotic you are given, how much ever costly it is not going to penetrate to that pus area. You have to remove. So that is one important thing. You have to involve the surgeon. First itself, if you are seeing a problem in this patient, suppose I am seeing a patient who is having cellulitis, there is a huge collection of pus. I am treating with gram-positive coverage, everything. I will give fluids, but this patient will not improve because pus is there continuously, it is spreading bacteria. So source control is very, very important. This is mainly occurring in surgical sepsis. Suppose peritonitis is there, you have to treat it. Suppose there is an appendicitis with a rupture, you have to treat it. So all these things will present as sepsis. Along with the sepsis management, you have to control the source also, wherever it is. Suppose there is a lung abscess, you try to do whatever maybe your modality of treatment, like putting an endoscope, removing the pus. All these things are possible. Nowadays, everything is possible. Whatever it is, source control has got very, very important role in managing sepsis. But most of the time, we forget that. We keep on treating the patient till the patient become like very bad. At that time, we will not be able to take the patient for surgery. Initially itself, involve the surgeon. If possible, go with the patient like anesthetist or emergency physician, go with the patient and assist them to do the surgery, because most of the time it may not be a major surgery. Immediately they can drain the pus. Okay. So source control wherever it is. Suppose it's a infective endocarditis, it may not be possible. You will have to give antibiotic only. But infective endocarditis, like sir told blood culture previously, infective endocarditis most of the time they may not go to sepsis, but they mimic sepsis. If you take a blood culture, it will be positive. They will have tachycardia, they will have hypotension, but they are actually not in sepsis. It is a cardiac problem with infection. But if you classify, that also will come under sepsis. So that type of problems can occur, but even then, if you can remove that foci of infection in the heart with the help of cardiac surgeon, that also resolves the infection. Wherever there is pus, remove it. That is mainly source control. Then, like sir told, depending upon the antibiotic of choice, you exactly hit that organism. Yeah. Once you get a culture report continuing that broad spectrum, may not be correct. You target that organism with specific antibiotics. And penetration is very important. That antibiotic which you are giving should penetrate. Otherwise, it will be like if you are seeing that everything will be sensitive. But that antibiotic is not penetrating to that area. So that is also very important. In that, all these conditions, we require, emergency physician require help of microbiologist or infectious disease. It's a teamwork. And a surgeon is very, very important when we are talking about source control. Because as an emergency physician, we may not be knowing everything about antibiotic. We may be knowing that levofloxacin will cover gram-positive infection. But we don't know where all it will go and act. So in that case, we require help of microbiologist and infectious disease. And to control the pus, source of pus, we require surgeon's initiative. All these things are important in source controlling. But whatever it is, source control is one of the most important aspect in managing severe sepsis cases.
Okay. Thank you, sir. I think sir really emphasized the point of teamwork also in the management of sepsis, and never forget regarding the source control. Now, I think we have covered reasonably the general principles of management, but we need to cover certain more areas with specific age groups and specific scenarios. Next question is to Deepu. Deepu, when we see the data on sepsis and all, we see there is a disproportionately high incidence in children or pediatric or neonatal age group. So, if you can just share your insights regarding the same, regarding the management in children.
Okay. At the outset, I should tell that I am not a pediatrician, but still I can tell the basic, broader principles regarding the management of sepsis in pediatrics. So, of course, one is the blood pressure. The blood pressure cutoff itself is different in case of pediatric individual. Less than 1 year old, the systolic BP less than 60 is the cutoff, and from then onwards it is 60 plus 6 into 2, 6 into x is the age. So that is the factor by which we have to understand that a particular kid is in septic shock or not. And with the newborn kids, the organisms are kind of also little different. For example, gram-positive cocci, including the streptococcus, is kind of very common in the neonatal age group. Even the HSV viremia is kind of very common. So these are very age specific or time specific. But as the child grows older, the spectrum of organism will start mimicking as that of the older age group. Okay. And also when we deal with a sepsis septic shock in children and newborns, it is not always as straightforward as that of the adults. There are a lot of other DDs of sepsis as well in neonatal as well as the pediatric age group. This include the inborn errors of metabolism like galactosemia and all. So that will mimic exactly like sepsis with hypotension, tachycardia, and all the other features of the sepsis will be there. And even if the patient is having congenital heart disease with patent ductus arteriosus, and if the circulation is dependent on the PDA, at the time of PDA closure, again the patient can develop a sepsis kind of presentation. Okay. Hypoglycemia can present as sepsis. So we need to understand that there are many sepsis mimickers in that age group. So, and listeria, less than 1 year, listeria is something which we always have to cover. So, ampicillin plus aminoglycoside is kind of a very frequently used combination in that age group. Whereas in case of older children, again it is if the patient is presenting with sepsis, BLI is kind of commonly used.
Okay. I would like to add a few things about neonatal and pediatric. PCT, procalcitonin, is raised in neonates. Okay. Till 72 hours, it is raised. So higher procalcitonin in a neonate doesn't make any difference. Okay. So it's only after 72 hours of procalcitonin more than 0.5 would be a significant marker. Okay. Second, the blood cultures in neonates, the blood volume is very less. Okay. So ideally 8 to 10 ml of blood is in adults. So neonates and children, you have a pediatric blood culture bottles where you can put 0.5 to 2 ml or 1 ml and do a blood culture. The yield is good. So always order a pediatric blood culture for neonates and children. And the pediatric blood culture bottles are always aerobic. There is no anaerobic blood culture bottles for pediatrics.
Okay, sir. Thank you, sir. I think another specific scenario where we need to remember is sepsis in HIV patients. So, though the core principles remain same, is there anything specific we need to look out for in HIV patients?
So once we understand the pathophysiology of HIV, it will be easy for you, because HIV is a virus which infects a person. It kills the CD4 cells in our body qualitatively and quantitatively. Its quality is reduced, quantity is reduced. But normally it takes many years. Suppose somebody is infected today, it takes 5 to 8 years to reduce his immunity. Because CD4 count, normal CD4 count is somewhere around 500 to 1200. From that 800 or 700, which is normal in many patients, to drop to 500, it takes minimum 5 to 6 years. Till then, he is a normal person. Whatever infection we have discussed so far, that is possible in that person also. Again, when it is less than 200, previously it was called as AIDS, acquired immunodeficiency syndrome. Even at 200 also, they may not develop much of the infection like what we are reading books. Most common infection what we have seen in our clinical practice is PCP pneumonia. But remember, PCP pneumonia will not, clinically, it will not produce sepsis, what is defined in most of the guidelines. They develop severe breathlessness, disproportionate breathlessness. They see the X-rays, sometimes it will be normal. Clinically, he will be severely breathless. And there are a lot of other things. You told special situation, that's why I'm telling.
Yes, sir.
One of the important thing what you should understand is most of these patients are on drugs like tenofovir, lamivudine, all these things. These drugs can produce lactic acidosis. So many patients who is admitted to emergency room, sometimes you are seeing lactic acidosis. That is not due to sepsis. He is admitted with some diseases like pneumonia, but he is on tenofovir or something like that. These drugs can produce some lactate. So lactic acidosis can occur. Even mild lactate can be more in this type of patients. So that's an exacerbation of clinical finding what we have explained. But unfortunately, when this type of patient come to ER, we should never stop the drug. If it is creating a big problem in management, then only we should stop. We should try to continue along with your acute treatment. So that is one important thing. But if the patient CD4 is very low, their immune response is very, very low. So again, you are in trouble. Most of the clinical findings, what we explained so far, it may not be there in that patient. This patient will come like a normal person, but he will be severely sick. All these clinical findings are masked because he does not have anything to fight. No cells are there to fight. So there is no immune response. So it's completely deregulated. There is no immunity at all. So he will not show any signs of inflammation or infection or sepsis. He may have hypotension. Again, hypotension, there are a lot of other causes. These patients can have TB. This patient can have fungal infection. They can directly involve your adrenal glands. Adrenalitis is possible. That itself will produce hypotension. So again, false information, lot of false finding you get in HIV. Sometimes we overdiagnose sepsis, sometimes we underdiagnose sepsis. For that, detailed history, detailed examination, then you should know what all things happens at each stage of HIV infection. Up to 500, most of the infections are same as any other patient. 200 to 500, normally what you are seeing is PCP pneumonia. Less than 50, 200 to 50. Less than 50, you get all type of opportunistic infection. Then fungal infections also very, very common. Even tuberculosis can produce sepsis in a patient who is having severely sick. Normally, TB will never produce sepsis in normal person. But a patient who is having HIV with very, very low CD4 count, they can have TB bacteremia, sepsis, everything. But unfortunately, we'll miss all the findings. That is a problem in HIV patients. And one more important thing is like hypertension and all. Dr. Krishna has already told we can give steroids. And many other conditions also we'll have to give steroids. But many think that HIV already immunity is very low. We don't try steroids. We don't want to give steroids. We are afraid of steroids. It is not like that. Even in that condition, the acute management is very, very important. We will have to give steroids. These are some important points. I cannot tell all the points in HIV how to manage, but important things you should remember in emergency room. But remember not to stop the drug what he is taking. He will be on ART. Unnecessarily stopping this drug can produce failure of that drug because these drugs are very costly. Even one day stopping can produce at least 5% chance of resistance. So try not to stop the drugs. Only with a consultant help you try to stop. If there is a major reason for stopping, you stop because some patients can develop severe rashes or some liver failure or renal failure. Stop it. Otherwise, don't stop it. Continue the drug.
Next question is to Anil sir. So there is a lot of interest in again rapid diagnostics and molecular based test in sepsis diagnosis is also very much discussed. So what are the real pros and cons of such tests?
Yeah, what Dr. Sabrish intended to say is a syndromic approach to diagnosis of infectious disease. That's a very relevant point and it's coming up in a big way. And that's a multiplex PCR. A multiplex PCR picking up most of the relevant pathogens at the same go in a single setting, and you rule out many pathogens in a single PCR reaction. That's a very good test, a robust test, but it's expensive, comes at a price. But you have to know where to apply it. The application of the multiplex PCR is what that is important. We have a tropical fever panel. A tropical fever panel will rule out typhoid, leptospirosis, dengue, West Nile, everything will, most of the relevant ones, and it has called pseudomyeli also in it, fortunately. And we in fact picked up a pseudomyeli with using a tropical fever panel. So you should know what is available in your panel. And you should always talk to the your microbiologist or the molecular biologist who is doing it, and discuss with them before ordering a test, because it doesn't make sense spending so much money on a patient where you can't pick up those organisms. So you should discuss with them and then go for a panel. Then what the sample? So many people try to use this respiratory panel in case of that picks up multiple viruses, at least 21 pathogens in a single setting, bacteria and viruses together, in sputum sample, BAL sample or tracheal aspirate. Now you see the list of pathogens: E. coli, Klebsiella, Acinetobacter, Pseudomonas, Burkhardt, everything. It will pick up multiple pathogens in a non-sterile specimen. So if you send a non-sterile specimen, you have to take it with a pinch of salt. So you just can't say that he is getting all these infections. These are all colonizers of respiratory tract, and a patient in our tertiary care hospital who is ventilated will have these pathogens in it. That can be only quantified to know whether it's significant or not. So quantitative culture of BAL is the far better when compared to doing a multiplex PCR. And a viral PCR also doesn't make any sense if you have a bacterial pneumonia. So don't waste your money in doing viral PCRs for respiratory pathogens. Only viral PCRs are significant if you have a respiratory sort of an infection in your ER coming in the community acquired infection, and you do a viral PCR, that is more significant to rule out viral infections, common cold virus, HIV, N1 coronavirus, whatever you want. But don't do it in a patient who is on ventilated on a hospital setting. So you are wasting your money technically. Then you have to think of meningitis and encephalitis, differentiate them, and then, because cost is a huge difference. You want to do bacteria, it's cheaper. If you want to do virus alone, it's maybe a bit expensive. But if you do pan-encephalitis, bacteria, virus, parasite, everything, it's huge cost, 15,000-20,000. So first rule out TB. You have a gene expert with us.
Okay.
That's a 2,000 rupees test. Rule out TB, then go ahead with other rare pathogens that you want to. And as Dr. Girish sir has already told about HIV, a very robust test for HIV is cryptococcal meningitis antigen test. So it's easily available, rapidly done, can be done in a card test. HIV patients will have predisposing for cryptococcal meningitis, and it can be done in serum samples also. So that you can rule out by using a rapid card test. So these tests are very robust, but you have to use with caution after discussing with the lab which does it, because interpretation will be very difficult. If you get multiple things coming positive at the same time, what will you do with it? And the patient may question that you are getting so many positive and you're not treating the patient in the first place. So that you should always be aware that using these tests should be selectively done. You don't bombard this test for every patient who lands up in your ICU. Use tropical fever in a PUO setting where you think it could be malaria also. It picks up. And PCT is raised in malaria. So the PCT is raised, you don't think it's bacterial sepsis. It could be malaria also if you have the environmental factors for that particular patient. So then the panel that is available right now is a BioFire panel that can be done in all the hospitals. BioFire does meningitis, gastrointestinal disease, and respiratory panel.
Okay.
There is no panel for directly from blood. So it's only blood cultures.
Okay.
So if you have somebody who is offering a multiplex PCR directly from blood, it makes sense. Not from blood cultures. So blood cultures BioFire doesn't have as of now, but meningitis, encephalitis, and GI panel, GI pathogens in a single multiplex PCR, you can rule out the GI parasites in case of HIV. In HIV, we can pick up all the cryptosporidium in case of multiplex PCR. So those things can be done, but judiciously after discussing with your lab who does it. Only then you will be able to interpret it. Otherwise, it doesn't make any sense. It's a waste of money.
Okay, sir. Thank you, sir. Next question to Krishna. Krishna, again, we have been hearing a lot about extracorporeal therapies, including cytosorb and all in sepsis, and especially septic shock. If you can share some thoughts on it.
So again, the upcoming field of cytosorb therapy, the endotoxin removal. When we discuss with the family that this is a problem that this patient is having, the question obviously is how can we remove that from our body, doctor? That is the next question. So we said that we'll give antibiotics, and because Google is available easily, so they will Google it. Why not we start this therapy, and they will be coming us regarding starting the cytosorb therapy and all those things. So again, it should be only for your reserved patient category. It should be the final option for a patient who is going to be really, you need this. You need to send maybe an endotoxin level, and you need to prove that definitely that cytosorb therapy is going to help this patient, because those group of viable patients, those who can make them survive after doing this therapy, should be ideally selected, because the cost factor is huge, and again the availability is not there in all the hospitals. So once you offer this therapy, you need to be very clear that the cost factor, and regarding the patient selection, again maybe after the cytosol therapy there can be an immediate clinical deterioration maybe within the next 2 days, because suddenly you're removing it will not just specifically remove, it will just the molecular weight, and it will remove all your proteins and everything. So suddenly there can be sudden worsening also. So that is one possibility that you need to consider. So again, there are a lot of discussion regarding hemofiltration, the classical hemodialysis, adding on a filter to it and doing a plasmapheresis associated polymyxin B hemoperfusion. These are all therapies that has been using. Maybe we have to be very specific in selecting these therapies, and patient selection is the most priority, and this is the key here when you are discussing in terms of an sepsis where you have multi-drug resistant organism, that you can do anything else. Maybe a post-transplant patient, you need to have really give it a try. So that is a role when really we need to think regarding the cytosol therapy or the polymyxin B hemoperfusion, where I think we had very good result for our post-transplant sepsis cases. So definitely it should be judiciously used, not offered for all the patient, depending upon the clinical scenario. And you need to, maybe if it is available, you send an endotoxin level and see if it is very high, then those group of patient is going to be benefited from your therapy. And again, as I mentioned, the cost factor is again very important. Maybe we may be coupling with an ECMO. You have an ECMO circuit, maybe you can add on a polymyxin B. So this all require a multidisciplinary team. It is not to be done by an individual. You should have a care conference for that patient. You need to have your nephrologist, your ID team involved, the primary treating physician, the hemoperfusionist involved, and everyone. And you should discuss regarding this patient and how the cost versus benefit. Definitely you need to discuss and take a call on it. Should not be offered for all the patient. It will be very specific. That
Do we need a culture positive for this?
No, sir. So I think we'll move on to the last pre-planned question for the day. Audience, I'm seeing some comments there. We'll move on to that questions. Anybody else have any questions which you feel we have not discussed? Please feel free to put it in the chat box. So the last planned question is to Deepu. Deepu, antimicrobial resistance is a major concern for all of us. And we are seeing a lot of resistant organisms growing up in cultures upfront. So do you see a solution for this, or how are we going to tackle this?
So it's a very relevant and current question, and all of us has to ponder about that question, because otherwise it is going to be the leading cause of death in the near future, the antimicrobial resistance. Just to take an example, we know that Salmonella was sensitive to almost all the drug, including Salmonella typhi was sensitive to all the drug, including quinolones. But there was quinolone resistance. Then we started using ceftriaxone, and now we are seeing ceftriaxone resistant. And so hence currently we have to treat with ceftriaxone plus azithromycin to get a proper response. So and since there is since from the onset of the COVID time, we are using azithromycin also more rampantly. So now it is just a question of time before azithromycin also is going to be resistant. And from elsewhere we are hearing the report that they have even got meropenem resistant Salmonella typhi. So from this story, the idea which I want everyone to ponder is that the more and more use of antibiotic is never going to solve the issue of antibiotic resistance. You can come up with new antibiotic, and within no time it also will be resistant if the consumption is if the prescription of the antibiotic is not managed appropriately. So definitely as far as prescribers are concerned, we need to use that rationale whenever as sepsis is definitely a condition where we have to empirically start on broad spectrum, but we have to use all the microbiological facility which Dr. Anil sir has told us, so that we can come down on that empirical high-end antibiotic to the targeted therapy. That is one thing. So but antimicrobial resistance has to go much further than prescription. There has to be a central policy regarding the antimicrobial prescriptions, not only the prescriptions but also regulating the indiscriminatory antibiotic use in the poultry and other farm areas, as well as in animal husbandry, so that the general antibiotic consumption and the general antibiotic resistance will come down. So definitely there has to be a central will, the government will, and there has to be policy, so that the antimicrobial resistance will eventually come down. And all hospitals has to have an antibiotic stewardship program, so that they can look into because when we have a multi-specialty hospital, there are so many peoples, and all of their expertise will be in different areas. So there will be lot of antibiotic misuse and abuse. So there has to be an antibiotic stewardship team who are carefully looking into all these aspects. And it is just like as we told that sepsis is a multidisciplinary management. Even the antibiotic choice can be a multidisciplinary thing. It is just a discussion, and we need to have that kind of openness to accept that kind of discussion, and whatever, and we have to tailor down to the minimum possible spectrum of antibiotic which is useful for that particular patient. So definitely this is something which we all have to understand, and we all have to put our heart into.
One small point.
Sure, sir.
Procalcitonin, if it goes down less than 80%, falls down 80% after you get a first value which is high, you can discontinue antibiotics.
Yes.
If procalcitonin is less than 0.5 repeatedly, you don't think of an infection, you can discontinue antibiotic if you are giving an antibiotic.
Also, clearance of 50% in 48 hours is considered as
Yeah. You can de-escalate. You de-escalate.
Yeah.
Discontinuation is less than 80%, you go down 0.5, you can actually discontinue. But you have to look at the principles that Dr. Deepu had already told you. Candidemia requires 14 days of treatment irrespective of procalcitonin. MRSA requires a 14 days of treatment irrespective of procalcitonin. Meningitis may require longer, osteomyelitis may require longer. So don't go by procalcitonin in these cases where you have to give a longer duration of antibiotics.
Okay. Now we'll move on to the questions. We had more than 100 viewers at a certain point of time, and we will try to take questions which we have not discussed in the due course. We have greetings coming from viewers from Qatar, Kenya, Ukraine. Thank you, Pakistan, Georgia. Thank you all. So Aishwarya is asking about fluid therapy in sepsis. We already discussed on it. Dr. D.K. Patel has a question which was discussed. Investigation of choice in sepsis. I think we broadly discussed on that also.
Regarding fluid therapy in sepsis.
Yeah, please.
Regarding fluid therapy in sepsis, as Dr. Srishnan has told, 30 ml per kg. But in pediatrics, in the surviving sepsis campaign, it is 40 ml per kg.
Yes.
And in the first hour, it is 10 to 20 ml per kg. So that is the difference in fluid resuscitation as compared to adults in pediatric and children age group.
Okay. Sanya is asking if no organism is detected in blood cultures, what should be the line of treatment?
One addition is there for that question. In tertiary care centers, most of the patients what we are getting is almost treated with higher antibiotics. So you don't get most of the times blood culture. Then you'll have to clinically search where is the possible infection. Look for alternative like fungal infection, viral infection, everything. Sometimes it can be non-infectious inflammation like macrophage activation syndrome. Like a patient who admitted with snake bite, for example, he suddenly go to immune dysregulation syndrome due to something else. Antibiotic is not the treatment of choice. There something else is the treatment of choice. So that we should keep in mind. Nowadays, many patients are getting antibiotic from outside, wherever it is, whichever hospital it is. Either they take by themselves or some doctors treat with antibiotics. Most of the time we are getting culture negative. That is possible now.
Yeah.
Culture yield is only 13%, 13 to 15%. And you give an antibiotic holiday when the patient comes to your hospital in case of all PUOs, and then send a blood culture, because it doesn't make much sense to continue the same antibiotic again. And then send a blood culture. PUO, you can consecutively send 3 days, you can send blood cultures, at least 2 to 3 sets of blood cultures, consecutively of 3 days. Consecutively 3 days you can send to increase the yield. But that is an expensive proposition. But having said that, you can reduce antibiotics when you get a culture positive with an bacteria which is sensitive.
Granulocyte lymphocyte ratios are in diagnosing sepsis, the neutrophil lymphocyte ratio. Because again, that is one simple investigation that again in the emergency room with the help of a CBC. So you can just calculate the ratio. If the ratio is increasing, again, if it is going up like more than 3-7 or like that, you can say that the stress level is high on the patient. So it has got some correlation with sepsis. So that is again one simple marker that we can try.
CBC itself we can get the NLR. And
That's one thing that we can.
Volume of blood culture also. If you are sending the blood culture, you are not putting 8 to 10 ml of blood in each bottle in an adult patient. That also reduces the sensitivity of the blood culture.
Okay. Gokul is asking regarding SIRS, sepsis, severe sepsis, septic shock. There has been a lot of terms, but what is the current stand? What is the current terms used? Deepu, I think the severe sepsis is no more being considered.
Yeah, now it is more like Now it is more like multi-organ dysfunction syndrome rather than, like SIRS and all. As in the beginning of the topic, we have discussed that it is basically we will check the total count, heart rate, respiratory rate, temperature. So it could be bradycardia, it could be tachycardia, and we then along with two SIRS criteria, there has to be a focus of infection. But it is getting modified. So I don't know whether we can stick back to the original definitions.
Septic shock still holds good.
Yes.
Refractory septic shock is there. But previously what we had is sepsis with organ dysfunction. We can call it a severe sepsis with single organ dysfunction with more than one organ, because each organ has got a cutoff, like cardiac dysfunction, renal dysfunction, like multi-organ dysfunction syndrome. This can be used for maybe you want to tell the family, or maybe you want to communicate with the colleagues.
Prognostication.
Prognostication purpose. So as if sepsis septic shock is the standard, refractory septic shock, these are the standard accepted terminologies. As such, when you look into the newer updates, the terminologies of severe sepsis has not been used.
Okay. So next question I'll take from Dr. Akash Kant. I'll give it to Anil sir. So only if 2 blood culture bottles are positive only we will start antibiotics, or even if 1 bottle is positive and the patient is symptomatic, then we can start antibiotics?
That's a very, very relevant question. I think I conveyed the wrong message to you. Now, I forgot to tell you that there are recognized pathogens and recognized contaminants. Recognized pathogens is every organism's name that you remember, that is E. coli, Klebsiella, Staph aureus, Proteus, Salmonella, Enterococcus. All these are recognized pathogens. Some things that you see very rarely is coagulase negative staph, which is a contaminant. Recognized contaminants: coagulase negative staph, diphtheroids, bacillus, gram-positive bacilli, alpha-lytic strep, that is a skin commensal. These are recognized contaminants. Only when you find these recognized contaminants, 2 blood cultures drawn from 2 different sites within 2 days of each other is considered significant. 2 blood cultures drawn from 2 different sites within 2 days of each other. If they grow a recognized pathogen, then only it is significant. Otherwise, any blood culture growing E. coli, Klebsiella, Enterococcus, Pseudomonas, Proteus, Salmonella is a pathogen, treat it. Even 1 blood culture positive for Candida is a pathogen, treat it. Don't consider it as a contaminant. Hope I am clear about it.
Cannot be more clear than that.
For the registered participants, they can put their name in the chat box.
Yeah, registered participants who are viewing this, kindly put your name in the chat box for our reference for issuing certificates. Sanas is asking, please include clinical pharmacists in case discussion. Of course, we will consider that, and clinical pharmacist forms the backbone of our stewardship team. And Sunil is asking, which is the earliest diagnostic method for neonatal sepsis? Nothing specific.
Earliest neonatal sepsis.
Yeah, procalcitonin, as told, need not be a. Yeah, CRP remains one of the major tools. Yes.
High sensitivity CRP is one of the tool that can be used in neonatal sepsis. So even in adult, when you look at like a 10 or a 15 CRP, we are not considering much of it. But in a neonate, a mild increase of CRP from 10 to 15 has got very significance, and it suggests sepsis.
Yeah, blood culture is definitely a blood culture in neonates. It can even grow earlier, like within 24 to 36 hours. So blood culture has a higher yield.
72 hours later, you can do procalcitonin also.
Okay, after 72 hours, a repeat procalcitonin.
Okay, there's a question on specifics on management of sepsis in pregnancy. Anything probably postpartum?
Mainly management is almost same, but we should know about antibiotics. That is very, very important. What it like first trimester, second trimester, third trimester, what all antibiotics can be used, it should be very clear. Otherwise, a pathogen, all these things are almost same.
Yeah, maybe like before prescribing, you can check in your UpToDate or Medscape, see what is the category of the antibiotic, whether it's A, B, or C, D. So if it is not to be prescribed, then better not. At the end of the day, it is risk versus benefit.
Correct.
So if the antibiotic classes A, B, and all, definitely the benefit is more than the risk considering the clinical scenario. So try to use those group of antibiotics.
And postpartum can also, like postpartum sepsis, everything can be another challenge, no?
Yeah, but again, then breastfeeding will be the issue. So depending upon the secretion in the breast milk. Puerperal sepsis.
Okay, then Ashwin is asking, when do you consider adding vasopressin? Are you worried about splanchnic vasoconstriction?
It is again, the answer was very clear because rather than going for the full dose of noradrenaline, even if you have half the way through the dose of your noradrenaline, it is always better to add on vasopressin as the next line of agent. And again, splanchnic circulation, theoretically speaking, yes, it can be a possibility. Ischemia vasoconstriction can be a possibility. But again, you don't have any other option in that scenario. You need to add on your vasopressor agent. But definitely, you need to consider the risk versus benefit here.
Next question from Sanas, I'll give to Anil sir. Role of antibiogram in management of antibiotic resistance.
Yeah, that's a very tricky question because antibiogram is very, very pivotal in starting an empirical antibiotic in a hospital. And every hospital is supposed to have an antibiogram. Now, in our hospital, you see, it's a quaternary care hospital. Everything is hospital associated. Rarely we get a pure community patient coming up here. So our antibiogram may not reflect the antibiogram of a periphery hospital or private hospital which is catering to the community. And our antibiogram should be department specific also, because we get a lot of nephrology patients, transplant patients, oncology patients, and urology patients. So they should be having a different antibiogram because their subset of patients are totally different. So antibiogram, on the whole, a hospital antibiogram can be made, but it may not be applicable to your dermatology, may not be applicable to your gynecology people because they may not be seeing such resistance. But if you go to a GI surgery department or neurosurgery department, the antibiogram is totally different. So we should be having ideally a department specific antibiogram because they see different sets of patients. And if you have an organism of more than 30 in number, then only you can make an antibiogram. So you can't make antibiogram for organisms which are rarely isolated. It doesn't make any sense. Like Burkholderia pseudomallei, you may not get that many numbers. Salmonella typhi, we get 50 to 60 numbers, so we can get it. If you're not getting culture positive Salmonella typhi that many, so you may not be able to put an antibiogram of that. So ideally, you should be having an antibiogram, provided your lab does a good job of doing the susceptibility in the proper manner, so that the antibiotic susceptibility can be trusted, because you have different guidelines for, if your lab is an accredited NABL accredited lab, then very good, you will be having good antibiogram. You can develop an antibiogram for department specific as well as hospital on whole. We give an antibiogram based on organisms, E. coli, Klebsiella, Enterobacter, Salmonella typhi, Staph aureus, MRSA, and then we give it as specimen specific also, blood culture and urine also. So blood is very important because septics, you will be able to decide which antibiotic to be given in septic patients.
Sayan is asking how to manage sepsis along with thyroid storm and hyperthyroidism patient on carbimazole drug when the sepsis itself is supposed to be carbimazole induced.
Carbimazole cannot induce sepsis. Carbimazole can produce some problem in the neutrophil count, and count can be reduced and can produce sepsis. But whatever it is, the treatment, first, whenever you are treating a patient, first thing we have to understand is which is the most life-threatening event in that patient. Treat that. That is the first thing. You don't haphazardly treating first thyroid storm, then infection, then cardiac problem. Suppose the patient is having arrhythmia now, that should be treated now. Suppose the patient is having hypotension, that should be treated. So if normally in hyperthyroidism, what you are saying is tachycardia. Tachycardia is the most important problem. Because of tachycardia, patient is going to develop cardiac failure. So when you are giving fluid, you should be very careful in giving fluids this type of patients, because already patient is in failure. There you require ultrasound, IVC, collapsibility, all these things are very important in that type of patient. Or you give fluid challenge and see whether the patient is going to pulmonary edema or not. So all these things are important. But always try to treat what is the most important life-threatening event in this patient. Most of the time, a tachycardia or atrial fibrillation will be the life-threatening event in that patient. Sepsis may be there, but that should be treated first. Carbimazole can produce neutropenia. With the help of an endocrinologist or physician on floor, you should adjust the dose or change to some other drug, or drug-induced neutropenia, you can give CSF, colony stimulating factors. That can be tried, but all these things should be with the help of the specialist.
I think we overshot the scheduled timing by 10 minutes already, so I'll just take one more question and then we'll call today. I'll give that question to Dr. Deepu. Role of granulocyte stimulating factor in neutropenic sepsis.
Definitely, like in our practice also, we profoundly use granulocyte colony stimulating factor. Whether granulocyte colony stimulating factor per se is causing reduction in the mortality is again questionable, but definitely as the neutrophil counts improve, the chance of patient going into recurrent sepsis and, like the fungal infections. So those multi-drug resistant bugs as well as the atypical bugs, the chance of those bugs will definitely come down, and hence granulocyte colony stimulating factor has to be there as part of your treatment, but then mortality benefit has not yet been proven.
Okay, thank you. I think we have covered a majority of the key concepts in management of sepsis. It goes without saying that we will not be covering everything, and each of the questions which we discussed here can be discussed over a few hours itself. And we really appreciate all the audience who have been still sharing their questions. But sorry to say we won't be able to take more, but we will try to come up with individual sessions on the key questions which has been raised and which we have not discussed here today. So once again, thank you all for listening in, and special thanks to all the panelists who have spared their time, and I'm sure all of you leave this session with more knowledge, and knowledge which can be used to change your clinical practice. Thank you, and see you again. And one more thing, now AETCM is on Twitter also, so we are planning to come up with some exclusive Twitter contents also, so those who are on Twitter, try to follow us there. Thank you.
Thank you.
Thank you.
Stop live.